Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending the first session of this Learning Collaborative Empowerment and Self-Management of Diabetes, the Pharmacist and Diabetes Care. This is a live activity. At this moment, our lines are mute. If you have any questions, please save your questions to the end. You can either use the chat box and type your question, or if you would like to verbally ask a question, you can use your raise hand icon and your line will be unmuted. The National Center for Health and Public Housing provides training and technical assistance to community health centers, especially the public housing primary care grantees and the health centers located in or immediately accessible to public housing. We are funded by HRSA to provide this training and technical assistance. Before we get started and we hear from our great speaker, we would like to introduce the public housing resident demographics. There are around 2 million people living in public housing. 38% of these are children and 59% are female. Around 80 or over 80% are below the federal poverty level. 52% are white, 43% are African American, 25% Hispanic, and 38% have a disability. In regards to diabetes in health centers, this is data taken from UDS, and there is a number that is very important, and this is why diabetes is a HRSA priority, and that 32% of health center patients have an A1C greater than 9. So as you can see, regardless of the percentage of patients with diabetes, 32% of these patients have an A1C greater than 9. This information is taken from a great publication. This is a joint publication that HUD and the Centers for Disease Control and Prevention put together, and they compare the people living in HUD assisted housing with low-income renters and people in the United States and the general population. And as you can see, the diabetes percentage, as well as the other chronic medical conditions in those living in HUD assisted housing, are greater than the low-income renters and the adult population in the United States. So this afternoon or morning, if you are on the West Coast, we are going to hear from Teresita Lawson. She is the speaker for today's activity. And Teresita Lawson, RPH CDCES, is a bilingual, bicultural registered pharmacist licensed in New Jersey. Her role as clinical pharmacist for Zufall Health Center included implementation of and continued quality improvement initiatives for the clinical pharmacy services program at Zufall Health Center. She precepted 6th-year pharm students APPA rotation for Long Island University, Rutgers University, and Fairleigh Dickinson University, and her efforts helped to contract Zufall Health Center as a faculty site for Fairleigh Dickinson University College of Pharmacy. Together with the CMO, she brainstormed strategies to expand and sustain the CPS program through PDSA's plan based on the principle for the model for improvement, and she actively advocates for role expansion and provider status for pharmacists. Her dedication for patient-centered care prompted the organization to designate her as the organization PCMH project coordinator in charge of spearheading NCQA recognition for Zufall Health Center. Her efforts earned the organization Level 3 NCQA recognition for both the Dover and Morristown facilities. She earned her Bachelor of Science in Pharmacy at Arnold and Mary Schwartz College of Pharmacy of Long Island University and earned her board certification in diabetes education in 2011. Having practiced in the retail pharmacy arena since 1989, she has extensive experience in patient counseling and medication therapy management. Her role in Zufel Health Center has centered around direct patient care, patient education, and lifestyle modifications, adherence, monitoring, identification of potential medication-related problems and adverse events, and provided education as well as medication therapy management. She was an integral part of the Patient Safety and Clinical Pharmacy Services Collaborative, which has now graduated to the Alliance of Integrated Medication Management Collaborative, a national collaborative dedicated to advocating for pharmacists as member of the healthcare team. So without further ado, I will turn it over to Terry. Good afternoon, Terry.
Hello, everybody. Thank you, Dr. Leon. I hope everyone is well and healthy. We're going to start presenting on the pharmacist and diabetes care. So I hope that you're relaxed and enjoy the show. Next slide. So our objectives here, we're going to go over the prevalence, of course, in the United States and its economic burden. What are our opportunities as pharmacists? We need to look at the underserved areas. We're going to discuss some highlights from the standards and important concepts behind the patient-centered approach towards helping our patients meet target. And we're going to talk about a patient case that I have put together for this event. Next slide. So basically, the content is going to cover what I've said in the objectives. And as pharmacists, we're going to look at it through the lenses of the pharmacist patient care process, which is our patient-centered approach towards helping our patients. Next slide. And this is about the prevalence, and we could just, next slide. So the CDC report, the National Diabetes Statistics Report, this is where this data comes from, along with an ADA fact sheet, 2020. So 34.2 million people of all ages, representing about 10.5% of the population, has diabetes. That's 1 in 10 Americans. I really want to point out the fact that there's many of them that are undiagnosed, and there's 88 million with pre-diabetes. And in our older population, those are our very highest risk patients. They really are at a higher prevalent rate at 26.8%, anyone 65 and over. And that type 2 diabetes is no longer considered an adult disease. Our youths are being diagnosed at an alarming rate, 6,000 in 2018 were reported. And type 1, 1.6 million Americans suffer with that condition. Next slide. And diabetes seems to be more prevalent in certain racial and ethnic groups, very prevalent in the American Indian and Alaska Native population at greater than 14%. And again, I want to point out our seniors, 26% of their population has diabetes. So it does, there are some racial disparities associated with the condition. Next slide. So the cost is enormous, and this is from 2017, $327 billion in total economic burden. Individuals with diagnosed diabetes have healthcare costs that are 2.3 times higher than someone without. And 1 in 7 healthcare dollars is spent with complications, and 1 in 5 in caring for people with diabetes. and the price of insulin continues to soar. Next slide. So where is our focus as pharmacists, in my opinion, is in HRSA's medically underserved areas. Okay, these are areas that have been designated as being not so accessible to primary care services, so they lack that access. Within those areas, we have underserved populations that are subgroups living in that area. And they may have barriers associated with economic, cultural, language barriers. They may be homeless. They may be migrant farm workers. And health professional shortage areas are those areas designated as a low in providers. They have provider shortages. And the higher the score between 0 and 26, the higher the need in that particular area. Next slide. So here what I wanted to really point out is that the areas of highest prevalence for diabetes actually overlap, or they're almost identical to the medically underserved area and HPSA designation. So they literally overlap. This is where the greatest needs are. Next slide, please. So we're really looking at the perfect storm where we're having an aging population with comorbidities. We're all getting older and we're all getting sicker. There's a declining supply of physicians, and not just in primary care, but in specialists. We always had a challenge trying to find an endocrinologist for our patients. The Association of American Medical Colleges, they predicted back in 2020 that by 2020, the US is going to see 91,000 fewer physicians than will be needed. And according to HRSA, the shortage already exists. So as of 2014, the ratio in an HPSA were identified as 1 to 3,500. So to me, that's an unbelievable proportion or disproportion, if you will, of physician to people in need. So we can be part of this solution by relieving that burden, by enabling us to practice at the top of our licenses in these particular areas. And the problem is reimbursement, as we all know. I have provided a number of handouts. I hope I haven't overwhelmed you, but take a look at it. It really does speak to the issues revolving around why is it that we can't really practice at the top of our licenses sometimes. So next slide. So why are we in a position to really impact and fill the gap in patient care with diabetes is because 95% of the population lives within 5 miles of a pharmacy. And whether you're working in a retail store or in a hospital, we're always one of the most, if not the most, accessible healthcare team members for patients. So we could definitely fill the gap, and we could do it by several ways: health and wellness checks, chronic disease management, comprehensive medication management, and patient encounters and communications with those patients, where we use the pharmacist patient care process to really evaluate and determine what our best recommendations are for treatment. Next slide. So in 48 states, we can practice under collaborative care practice agreements. This is a practice that's been in place for many years with the Indian Health Service, as well as with the Department of Vets. But again, the problem still remains. Reimbursement is an issue. So more legislation is needed. In my handouts, you have certain bills that have been presented that are in Congress that ASHP actually recommends that you get involved and write letters to your congressmen and senators, etc. So you could see that in your handout. And these are some of the services that the Patient Protection and Affordable Care Act actually endorses for pharmacists to perform. Next slide. So as we were speaking before, medically underserved areas are recognized in these bills. These are the bills that are present. We can get granted provider status via this pathway. Other professionals have used this pathway, and I think that it is where we're most needed, obviously. And in 2012, the Centers for Medicare and Medicaid broadened the concept of medical staff. So the path is becoming more and more great because the need is more and more great. And we're definitely in a position to get involved. And I'm sure many of you are anyway. So next slide. And you could skip this. This is just the title. So there's 4 types of diabetes, right? So there's type 1, type 2, gestational, and then there's other forms that are out there, like monogenic diabetes syndromes, like in neonates, and MODY. Drugs can cause, can bring it on, and side effects can bring it on. So those are primarily the 4 typical categorizations of diabetes. Next slide. So we all know that it's a metabolic disorder. You're looking at an impairment in metabolism of carbs, proteins, and lipids. There's long-term damage with chronic hyperglycemia to our organ systems, primarily the eyes, kidneys, nerves, heart, and blood vessels. We're not too secure yet in the origin and etiology of DM, and it can really vary greatly. Type 1 is associated with immune mediated. There has been some controversy about latent autoimmune diabetes with adult onset, or LADI, and all autoimmune diabetes are going to be considered under the type 1 umbrella. And type 2 is the most prevalent, of course, in the spectrum, and it's characterized by hyperglycemia, insulin resistance, and a relative insulin deficiency that can progress to total lack of insulin production. There are genetic, environmental, and behavioral risk factors that can impact the severity of type 2 and its progression. But once hyperglycemia occurs, patients with all types of diabetes are at risk of developing the same chronic complications, although those rates of progression can vary depending on the patient and their comorbidities, right? And the degree of hyperglycemia also reflects the severity of the disease. So obviously, the longer the patient has sustains a hyperglycemic state, the more damage to the organ systems. Next slide, please. So type 1, again, autoimmune destruction of those pancreatic beta cells. The classification, of course, is important in determining our therapy and how we're going to proceed. But the symptoms sometimes overlap between the different classifications, right? So some traditional paradigms that we used to think of was type 1 only happens in the young population. Well, that no longer holds true. And type 2 only occurs in adults, also no longer holds true. So as indicated by the amount of youths that are diagnosed on a yearly basis. Another thing that is important here is that DKA is more associated with type 1 diabetes, but it can happen in type 2, and I've seen it happen in the Hispanic population. My population was mostly Hispanic, and it happened quite often in that population. And as far as gestational diabetes is concerned, it's important to screen patients at the appropriate time and catch them beforehand, right? So preconception care is important. And so the point here is that even though the symptomology may overlap and it may be difficult to determine whether the patient is type 1, type 2, or whatever, may be blurred in the beginning, but it does become more clear as time progresses. Next slide. So here I'm showing where and how the different types and classifications can overlap in symptomology. So it's difficult in the beginning to really determine with 100% certainty what class the patient falls into. But the degree of hyperglycemia can vary over time, right? And clinical symptomology may or may not be present, and those periods can also vary in our patients. Next slide. In type 1, you have three distinct stages. The first stage is pre-symptomatic, and the patients present with normal blood sugar, although they do have an autoimmunity present in their characteristics. By stage 2, they do become dysglycemia, but again, they do not have symptoms. So we do have an opportunity there to feasibly catch type 1 before it progresses and onsets as DKA. And both the FPG, the 2-hour postprandial, and the A1C are equally appropriate for diagnostic screening. Next slide. About 5 to 10% of all diabetes is type 1. Again, it is immune mediated. It's autoimmune destruction of the beta cells in the pancreas, and it usually leads to absolute insulin deficiency. And the autoantibodies are proportionally associated with predicting hyperglycemias. And they are present in 85 to 90% of individuals when fasting hyperglycemia is detected. Next slide. It's also thought to be related to environmental factors. The rate of beta cell destruction is variable. And mainly in infants and children, you will see a rapid progression, and they mostly present with DKA as a result of some sort of stress or infection. It's slower progression in mostly in adults, where they can present sometimes with what's called a honeymoon period, where they are not insulin deficient and they present with no need to initiate insulin at that point. Also, they may have manifest with undetectable levels of plasma C-peptide, which is co-secreted with insulin. So that might be a nice clinical tool. Patients are rarely obese, but don't rule it out. They can present as obese patients, and they also present with other autoimmune disorders. Next slide. So to summarize, For type 1, you have that autoimmunity component. Hyperglycemia can be present or not depending on the stage, but we do have an opportunity to catch it before it develops into DKA. Plasma C-peptide may be useful in clinical practice. The presence of an autoimmune disorder is also indicative of characterizing the type of diabetes. And DKA is more present in youth, especially in the presence of infection. And obesity is not commonplace, but don't rule it out. Next slide, please. Here are your common symptoms of diabetes. I'm not going to go over all of this, but I really wanted to point out the psychosocial care that's important. Most of my patients did present with anxiety, depression, behavioral issues that are important. Lifestyle, where do they live? How do they live? How do they make their income? Are they isolated, not isolated? Those psychosocial aspects are important to recognize, as well as the comorbid conditions associated with the condition. Next slide. So what are the recommendations regarding this? Psychosocial care should be integrated. Screening should be routinely done in people with diabetes, particularly those that are not meeting your target, or their target rather, or those that have been newly diagnosed. It's very scary for patients to be diagnosed with diabetes. It's a very scary condition, and this is something that I saw very commonly in my patient population. And simple tools are out there for our use and guidance in our conversations with our patients. And ADA posted a position statement, psychosocial care for people with diabetes. And there is a list of assessment tools in that publication, and I've also provided it to you as a handout. Next slide. So let's talk a little bit about diabetes. 1 in 3 adults now, age 20 and older. It's becoming an enormous issue. 88 million Americans, and 85% of them don't even know they have it. They walk around with it and they don't even know they have it. So we recommend really screening and treatment of modifiable risk factors like smoking, obesity, things that we can treat beforehand that are modifiable, right? Education, support programs that provide venues for our patients to really help them develop and maintain behaviors that will delay or prevent even the onset of type 2 diabetes. And that's where our tools like motivational interviewing come in. Next slide. So who should be screened? I'm not going to go through this whole list, but basically any one of our patients that meet factors and indicators that provide risk in those patients, right? That indicate risk. So if they're overweight, if they're of a certain race or ethnicity, like we spoke before, there are racial disparities. There is more prevalence in, for example, the Hispanic and the African American population as compared to non-white Hispanics. So anyone that falls within that risk group, hypertensive patients, people that don't exercise, women that have had gestational diabetes before. So all of your high risk population, really, that's who we should screen. Next slide. And these are your criteria for screening. I'm sure you're all familiar with it. The one thing that I want to point out here is in the absence of unequivocal hyperglycemia, okay, diagnosis requires 2 abnormal results from the same sample or 2 separate test samples. If they have outward hyperglycemia, classic, they have polyuria, polyphagia, and you do a point of a random plasma glucose, and it's greater than or equal to 200, that's diagnostic. Next slide. So the guidelines say at least 2 times a year in patients that are meeting goal. Those that aren't may require more frequent monitoring. Quarterly is suggested. For us, for pharmacists, and point of care testing is becoming more and more important. There's a lot of pharmacists that are performing point of care testing now. This is not only our opportunity to screen people and catch those that are walking around with prediabetes, but it also provides an opportunity to really motivate the patient and help them adhere to their medication regimen. I was notorious for running an A1C on my patient a month after starting metformin. And the reason why I did it was to help them see the benefit of the drug and the benefit of their efforts in trying to bring that condition into their hands, into their control. So it really, for me, it was a fantastic motivational tool early on to really secure and help secure adherence to the medication regimen, as well as to the lifestyle changes and modifications. Next slide. So some things to keep in mind about the A1C is there are certain disorders that can impact its accuracy. So you have anemias, you have end-stage kidney disease, you have medications, of course. You know, it's relative, right? So if your patient has certain conditions that can alter that test, you should move on to another way of testing that patient accurately. So it's recommended that you use a combination of evaluations and assessments. So self-management of blood glucose and continuous glucose monitoring, which is really becoming prevalent now, is a good way to evaluate and assess your patient's control using at least a combination of several results. Also, keep aware that your patients want to please you. And I had a lot of patients that wanted to please me and would bring in their self-monitoring blood glucose readings, and they were perfect and wonderful. And then I would look at their A1C and they were way off target. So obviously in situations like that, you need to sit down and really evaluate what's going on and speak with your patient and get to the bottom of it, you know. There are assays, many assays in the United States that are accurate. And if you want a list, you can go to the NGSP.org site. They have a list. And the A1C does show association with average glucose levels. And if you don't have someone's blood glucose readings, you could more or less average it out in your head. If you have someone that's at 9, well, that patient is really sustaining about on average 200 sugar in their blood. Next slide, please. So what are the recommendations? At least annual monitoring for the development of type 2 diabetes in those that have prediabetes. Patients with prediabetes should be referred to an intensive lifestyle and behavioral intervention program. They suggest modeling against the diabetes prevention program. And really, we're looking to help the patients maintain a 7% loss of initial body weight and work themselves into increasing moderate to intensity physical activity. So if you have someone that hasn't exercised ever, I wouldn't go advising them to go and do 150 minutes per week. That's something that through lifestyle and intervention programs like the DPP, we can help them move along that scale, right? And let the patient lead. And based on patient preference, there are technologies out there, as we're all aware. There's a lot of mobile apps and computer programs and all sorts of gadgets. But the one that I wanted to really point out for us as pharmacists is our opportunity to really get involved with telehealth. It's patient friendly, and even in the old days, before telehealth was, talked about so prevalently, I used to FaceTime with my patients. It's always a good tool, especially in that population that may have a cell phone and may not be their literacy level. You may be concerned about that. So in order to have that high frequent touch, telehealth is an option. And metformin therapy for the prevention of type 2 diabetes, it should be considered, especially in those that have, again, indicators of risk, right? So if you have your BMI at 35 or greater, patients that are less than 60 years old, and in women with prior gestational diabetes, it may be helpful in those scenarios. Always keep in mind the B12 deficiency that has been tied and associated with metformin, and they recommend periodic measurement of that level. I always recommended that my patients take a vitamin B complex. Next slide. So we all know that it's a risk for cardiovascular progression, screening and treatment of those modifiable risks like we spoke of before. Advise all patients to not use cigarettes and other tobacco products such as e-cigarettes and vaping. And after identifying those issues, include that smoking cessation counseling in your routine for that particular patient. Next slide, please. Continuous glucose monitoring is becoming more, as I said before, more utilized, and it's becoming a useful tool in clinical practice. And it should be considered, and the ambulatory glucose profile is advised. You have your time in ranges on that report. I'm going to show you a shot of that in just a moment, but in general, your goal would be about 70% in range, because that sort of correlates with an A1C at around 7%, at least in 2 studies, it showed that, and it is associated with the risk of microvascular complications. So the longer the patient is within that time in range of 70% or greater, is a benefit to microvascular complications. And time below and above target are also important because you're looking at your hypers and your hypoglycemia. And this offers an opportunity to address that issue with respect to the medications. Hypoglycemia unawareness is also an opportunity to address that issue with the patient. And it also offers the opportunity to start the conversation about intensification of the regimen and help prevent clinical inertia. Next slide. So here's that screenshot of the continuous glucose monitoring AGP report. This came right out of the standards. It is recommended to be worn 14 days. The glucose management indicator does approximate the A1C level in the patient at the time, so you can more or less know where they stand there. It also shows the variables between how long was the patient in hyperglycemia, what is the proportion of the time that the patient was hypoglycemia or hyperglycemic. And that's also been tied to complications, right? So our target there is less than or equal to 36%, then that's where you want your patients to be. And again, you want them to be in range at approximately 70% or better. Next slide. This is your targets. Obviously, the more complicated the patient, the more comorbidities they have, the less stringent you want your targets to be. The more less risky the patient's features are. If they were just newly diagnosed, they have no hypertension, their lipids are in control, they're not overweight, then you use less stringent. But every patient is their own universe. But in general, less than 7% is your target in non-pregnant adults. Less than 6.5 can be considered if there's no hypoglycemia. And less than 6% in pregnancy if there's no hypoglycemia. Sometimes they will go a little bit, less than 7 if there's no hypoglycemia, okay? And in our more delicate, more high-risk patients, like our elderly folks, less than 8 is an appropriate target. Some of my patients didn't do well there. Some of them did better at 8.1 or 8.2. It depends on your patient, but per the recommendations, in general, this is what you're looking at. Next slide. So hypoglycemia is a major effect. I'm going to fly by this because I'm running out of time and I want to make sure to hit the patient case. But teach your patients the 15-15 rule. That's 15 to 20 grams of glucose. It could be tablets, it could be liquid, it could be gel. And the patient must be conscious, obviously. You have to wait 15 minutes, let that absorb. Repeat it if the glucose is less than 70. Once above 70, have them sit down and have a meal. You got 3 levels of hypoglycemia, okay? Glucagon is for those at risk of level 2 hypoglycemia, and ongoing assessment of cognitive function is important in patients, especially in those at a higher risk of hypoglycemia. Next slide, please. Pharmacotherapeutic approaches. Type 1, you got your multiple prandial and basal injections and continuous infusion like pumps. That depends on patient preference. Type 1 and type 2, you have to teach injection techniques. IM, not good. Make sure they know the sites. Make sure that they know about rotating those sites. Type 2 diabetes, metformin and lifestyle are first line. It is to be considered in pre-diabetes despite FDA indications. And type 2, early introduction of insulin can be considered if you have a patient that is catabolic, but normally you would start with metformin if the patient isn't in this category. And you're also going to look at the comorbidities of that patient, right? What are their risks? Continue. Next slide. So you have your pharmacotherapeutic approaches that we're all familiar with, but what are we looking at with comprehensive medication management, right? We're looking at efficacy, hypoglycemia, weight change, cardiovascular effects. You're looking at cost, dosage form, oral or sub-Q, renal effects. You're looking at additional considerations that you might take into consideration, right? Adverse effects, contraindications. So when we're looking at our therapeutic approaches, those are the factors that will influence our decisions, right? And I'm going to cover that in a little while, a little deeper. Next slide, please. So when we're looking at this, at the guideline, we're looking at efficacy. It's high with metformin, GLPs, TZDs, sulfonylureas, and highest with insulin. When you look at this guideline, you have to take into consideration if the patient is at risk for ASCVD or CKD or heart failure. That would predominate over whatever their A1C is. So that's where your SGLT2s and your GLP1s play a significant role now. They have shown benefit with cardiovascular risk. However, just to put it out there, saxagliptin is a potential risk, though, in regards to heart failure. Metformin can show a potential for modest weight loss. SGLT2s and GLP1s are associated with loss. And then it's important to always keep in mind that TCDs, sulfonylureas, and insulin are associated with the highest weight gain. Costs, of course, very, very important, especially in the underserved areas. The lowest cost you have is metformin, your TCDs, your SUs, human insulin. All the rest are high, and the analogs are high. Your dosage form, you have to look at your patient preference. You know, some of them, we all know about needle fear, so you would start with orals, obviously metformin's first, but as you progress within that a regimen, you might progress into a sub-Q, and you might have to have some conversations with your patient regarding the benefit and risk of the drug. And that's what I'm going to say about the guideline and the pharmacological approach. Next slide, please. So how do we begin that conversation with patients, right? It's all about technique, but I think it's all about being a pharmacist too. We've always talked to our patients, so we know the technique that we need to use, which is basically, you know, eye contact. You welcome the patient and describe your role and intentions, because this is very important. So that the patient knows that, hey, you're there for them, and you're there to help them work through this condition and live happy and full lives. And ask open-ended questions. So if you ask a question like, what most concerns you about living with diabetes, you'll get an explosion from that patient, which is really, that's where we begin. That's where we begin with their emotions, feelings, whatever their barriers are, and that's what comes out of just that one question. Next slide. So here's Carmen. Here's our patient. She visited her PCP back well, let me start over. Today is the 24th, and you're visiting with the patient. The PCP was supposed to see her on the 9th of April, but she missed her appointment. Of course, this is a make-believe scenario, not living in a COVID environment, if you will. But anyway, the patient missed her appointment on the 9th. She's a 27-year-old Hispanic female. This is an initial visit with us. The PCP saw her on the 10th of March, where she presented with a urinary tract infection. She's a migrant from Mexico who recently migrated. She has 3 children and parents that are alive, and they all reside in Mexico, and has no family in the US. So you could look through this. She's a line cook. Her family, she's a first degree family members with type 2. She lives alone. She rents a room. She has 3 children and parents back in Mexico that she supports with what she earns here. She finished her medication without any issues, and her UTI has resolved. Next slide. So here's a poll question. What key specific factors about Carmen's presentation would you take into consideration in your initial assessment?
All right, so I'm going to go ahead and launch the poll question, and I'm going to give about 30 seconds for participants to respond. All right,
Okay. So you guys all got it. So definitely we need to consider all of the characteristics that the patient presents with in order to identify some of her issues and risks and how we're going to move forward. Next slide. So what do we need to look at with this patient? She needs access to food. She may have some food instability or insecurity. What community resources can we tap into for this patient? We maybe should approach the issue of contraception. She is a female of childbearing age, and she does have a heterosexual partner, so that may be part of what we're thinking of when it comes to what issues we need to address or pay attention to help Carmen. Next slide. There are definitely a lot of resources out there. Depression screening. She was teary, very upset and anxious about her diabetes. So we need to really keep conscious of that. And there are a lot of assessment tools out there. They're in the slides. I've provided the links. I highly recommend that you pay attention to how your patient presents psychosocially. Next slide. So what conditions will impact your treatment recommendations? All right, so yes, she's pre-diabetic. Definitely that is at the top of the list. And along with that, we also need to address her lipids, right? She's definitely obese and she's definitely hypertensive. Next slide. So we might go with an ARB and ACE. We need to cover the adverse effects of those drugs, right? We would do that with any medication that we would suggest for the patient. Her LDL is above 190, so we need to consider statins, lifestyle changes. Also, you may want to introduce the patient to some nutritional guidance, a plate method, accessible technologies. ADA has a program on the web for patients, right? And a frequent touch. The telehealth, again, folks, is going to help this patient tremendously. Next slide. So is metformin an appropriate medication to consider for Carmen? That's cool. I believe that I'm among the 88%. I definitely see a role for metformin. I have provided a meta-analysis for you because what dose should we give, right? So in this particular meta-analysis, it showed that a higher dose and a lower dose, really there was no difference. So I would always go with any medication. I always go with the lowest dose possible that could be effective and not harmful to the patient. So I think that I'm with you guys. Next slide. How do we talk about medications? Shared decision making. There's a great publication. It's called The Share Approach. It's a working curriculum from AHRQ on how to utilize decision making in our encounters. Now, I think that pharmacists, we've been doing this for a very long time, but not as formally, right? We know how to talk about medications, but this can really provide a tool for us to start the conversation and help the patient move through the decision-making process, which also engages the patient. So it's very, 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 very helpful tool for us. Next slide. Here are some shared decision-making tool resources that provide English and Spanish handouts. There's also an online interactive tool, and I provided the link here for you. Next slide. And this is what it looks like. On the upper right-hand corner, you could see you could change it to Spanish or English, and you could discuss the benefits, what's in it for the patient, right? Because that's what's going to motivate that patient to become engaged, at least interested in what you've got to say. Hey, look, this is what it can do for you. Is a very important concept to approach with the patient. And this tool really, really helps you do that. Next slide. So what will the SMART goals be? Okay, so definitely, I would definitely handle the A1C first. I agree with you. Definitely psychosocial issues. I'm really happy to see that, because one of the things that we don't want to do is overwhelm our patients. Next slide. So the specific, this may be a discussion on what behavior would the patient like to tackle first, right? Food choices, how much exercise, skipping meals, what's relevant to the patient, what's attainable, what's measurable, time bound. When it comes to her weight, hey, that's a sensitive subject. So she's got to lose about 7%. Can we help her do it? It depends on her. How much is it important to her? Like, how relevant is it to her on a scale from 1 to 10? Where does she fall? Is she more motivated to lose weight or less motivated? Or is she happy the way she is? So this is a particular conversation that can utilize motivational interviewing, right? And see where the patient is, what's important to them. And that's how you would formulate these SMART goals. Really is my point, is it's all about the patient. Let the patient decide, and then you could formulate your SMART goals. Next slide. Follow up and evaluate. This is something that we're going to be doing on a continuous basis. The higher the touch, the better. because you can see where your patient, how your patient is progressing, where that patient may need care, where they need more support. Is there another community service that we have tapped into since? By the way, I highly suggest a tap into the community, know what your resources are, so that you can help your patients reach their goals better. Education support, you're always going to monitor those medications, right? For side effects, what's the best choice? And you're always going to make that patient feel welcome, comfortable, and communications with your team. Always, I always found that the interdisciplinary approach was always the best approach, because everyone brings in their expertise, everyone brings in what they can do for the patient, and everyone's on the same page, right? So communications, very, very important. So that's all I have, folks. I'm sorry that I rushed through some of the slides. I know I was running out of time, but you'll get the slides. You'll also get all of the handouts that I put together for you. And I hope that I've helped you help your patients a little bit better today. Have a great day.
Thank you, Terry, for this great presentation. And we're going to do the Q&A right now. Some housekeeping items before we go into the Q&A. We are going to have our next session on May 14th from 1 to 2:15. This is going to be on the nutrition, dietary choices, and lifestyle changes for patients with diabetes. The registration link is just below the announcement. Remember that you are going to get a copy of the slides just after this live presentation, as well as all the resources that Terry mentioned. The fact sheets and the other documents that you can download them from GoToWebinar, but they will also be included in the email that you are going to receive after this webinar. So if you would like to ask a question, you can either use the chat box, type your question, or if you would like to verbally ask a question to Terry, just use the raise hand icon and your line will be unmuted. And one more housekeeping item, please remember to complete the post survey. Your feedback is really important to us, and it helps us to improve our webinars and learning collaboratives and all the training activities that we do. Do we have any questions, Peter?
No, not at the moment.
No, not at the moment. Okay. Terry, when I was going over your presentation, or when you were going over your presentation, you mentioned the different items and different situations, or events that probably many or some of the team-based members can also take care of. Like it's very difficult for a clinician or for a PCP, for instance, to give all this information in a 20-minute visit. So they have to rely on the nurse to provide other information. If the patient has any social determinants of health that needs to be addressed, they go to the social worker. If the health center has a nutritionist, then the nutritionist will provide some information on the diet, and lifestyle changes. So when the pharmacist is basically the person who has the contact, a very direct contact with the patient after all these visits. So based on your experience, not only as a pharmacist, but as a diabetes educator, what are the most common questions or doubts that you see in the diabetic population that you served?
So what other needs did the patient have?
No, but you know, sometimes either because health literacy issues, they didn't understand, you know, some of the instructions, so they need somehow to go over the instruction with somebody else. You
Right.
know, what are the main concerns that you see in patients when they go to for their prescription, you know, and they have a conversation with you?
Well, if they're, again, if they're newly diagnosed, and this is the first time they're presenting at the pharmacy with metformin, that's been, or in an encounter with me, because I didn't dispense, I just saw patients. So when in those instances, I found patients to be very, very anxious, very, very scared. What I saw most commonly were teary presentations and anxiety, cost issues, side effect issues. Of course, I was fortunate enough to be able to refer my patients to behavioral health to help them with those psychosocial issues that they would report. How am I going to afford this medication? You know, metformin is cheap, but cheapness is relative, right? So $11, $15 for you and me may not be anything, but $14, $15 to someone that makes maybe $50, $60 a day is a lot of money.
Right.
So it's relative. So I did see a lot of that in my population. They were very, very poor, extremely below the poverty level. And cost was always a big concern for them. Nutrition was a big concern for them. Culture plays a big role, and food is part of our culture. So when you're looking at an individual that's eating rice and beans and plantains and mainly starchy vegetables in their diet, and now all of a sudden they have to sort of start restructuring that diet a little bit. I saw that. I saw that a lot, and I tapped into resources in the community for that. There were free nutritionists at ShopRite at the time. I think they're still there. And they're free to the patient. So it's a resource. Pantries, community pantries, another resource. If you're working with community health workers, usually they can tap into other resources that you may not know about, So it's with respect to what was common to see in my population, I would say that those features were very prominent.
Thank you, Terry. Fide, any questions in the queue? No questions?
No.
Okay. All right. So again, remember that this activity was recorded. The video, the recording, the slides, and the handouts will be sent to you after the webinar is over. Please go to our website, www.nchph.org. You will find information on funding opportunities, HRSA updates, webinars, resources and services that we provide, as well as publications. And if you have any questions, please feel free to contact any of our staff members. You can also go to our website and use the training and technical assistant tab, and you can type your question and send it to us. Once again, thank you so much for participating in this activity. Please don't forget to complete the post survey, and have a great evening, have a great weekend, And please stay healthy and stay well. Thank you and have a great afternoon.